Lovely. Welcome to Journal Club, and Chris, Alex and Brent are going to present this week.
All right, good afternoon, everybody. We will be presenting the TOMAHAWK study, which was published recently. Firstly, we'd like to say thank you. Firstly, we'd like to just say thank you to... Well, let me just try and get rid of this echo quickly.
I'm off. Oh, sorry. Oh, I can hear.
All right, apologies for that. So I'd just like to give credit to Dr. O'Mahan, who put this presentation together and has allowed us to use it for our presentation today. So the TOMAHAWK study was a study that was looking into whether it's a good idea to do angiography and plus minus PCI after an out-of-hospital cardiac arrest for patients without the presence of ST elevation. So this study was published recently. Chris, next slide, please. So it was published in the New England Journal of Medicine. Many contributing authors, as you can see there. And it was quite a large study, which did back onto a couple of recent papers or studies that we will talk about as well. The idea behind it arises from the recent guidelines that have been published by the European Resus Council. So the ERC guidelines have come out and said that emergency coronary angiography should be considered for anybody who's had an out-of-hospital cardiac arrest if there is a high clinical suspicion of coronary artery occlusion. So in the presence of non-ST elevation, this would be things like cardiogenic shock, recurrent, unstable, and arrhythmias, amongst other causes. So the question that was published by this paper, sorry, just back there we go, yeah, is basically they took patients over the age of 30 who had suffered an out-of-hospital cardiac arrest, who had obtained ROSC prior to arriving at hospital or shortly after arrival. They had no ST elevation on their ECG, and they wanted to know, was routine coronary angiography in the cath lab suitable, and does it improve 30-day all-cause mortality compared to a delayed or more selective approach? So the more sort of recent studies that were done that have been published, so this first one, as you can see, is COACT back in 2019 in the EGAM, basically looked at, it was a multi-center study between January 2015 and July 2018 in the Netherlands, where they took 538 patients across 19 centers, all of which had had an out-of-hospital cardiac arrest. They'd had shockable rhythms of note, and they had no neurological recovery, but all of them had had ROSC. So basically, patients who'd got ROSC from a shockable rhythm, but it had no neurological recovery and no evidence of ST elevation on ECG. They randomized the patients into getting angiography within 2 hours, or once they'd made a neurological recovery, provided they made neurological recovery. The study proved that there was no difference in 90-day survival, nor was there any difference in any of the subgroup analyses that are listed there. The next sort of study that was started was a pilot study that was published in Resuscitation in 2019 called DISCO. It was an initiation, sort of was a pilot study which was then stopped, and basically they looked at 79 patients over the age of 18 who'd had an out-of-hospital cardiac arrest and no evidence of ST elevation on their ECG, who'd obtained ROSC. Of these 79 patients, an angiography was performed in all of them, and 37% of these patients were found to have a culprit lesion. So obviously this was a sort of very small study, and the contrasting evidence between the two papers as to whether it's beneficial or not led to sort of the TOMAHAWK study being a necessity. So the ideas that the authors have looked at in terms of the study is, what are the benefits and potential risks, firstly, of doing immediate angiography in these patients? So obviously, if you do an immediate angio in patients who've got coronary lesions, you can treat a culprit lesion quickly, which obviously reduces your risk of repeat cardiac arrest or ongoing or further myocardial injury, improves your hemodynamics, and prevents the chance of further or development of heart failure. However, the problems or potential risks that could come from immediate coronary angiography is that if there is no culprit lesion and you've taken a patient to angio who didn't need angio, you can obviously delay other treatments or etiologies that may have caused the arrest, and in thus doing so, increase the risk of a further arrest. The other things of note is that you can get complications of angiograms. They're not without risks, as we all know, and the risks of them are listed there. But it was something that was taken into consideration for the study. So the inclusion criteria that was for this study was patients over the age of 30 who'd had a documented out-of-hospital cardiac arrest, shockable and non-shockable rhythms of note. So that contradicts the study earlier, which was just looking at shockable rhythms. And importantly, they got informed consent. Now, these were patients who had ROSC. It was patients who had neurological recovery or had sort of consent gained through other, recognized means. In terms of exclusion criteria, importantly, so evidence of ST elevation or left bundle branch block. So this was, so I suppose you could debate the sort of exclusion of old left bundle branch blocks. However, some of these patients didn't know whether they were new or old, but certainly new ST elevation was an exclusion criteria. Obviously, if a patient hadn't obtained ROSC by the time they were sort of admitted to hospital or shortly after hospital, they were excluded. If patients were obviously at needing angiography for a clinical indication, this excluded them from the trial because they weren't able to be randomized. And then any obvious other cause of cardiac arrest that was obvious in these patients was an exclusion criteria. And then lastly, this was obviously looking at out-of-hospital cardiac arrests. So patients in hospital were excluded, and then pregnancy and other trials were also exclusion criteria. So if we look at the breakdown of their study, so these are survivors of out-of-hospital cardiac arrest without new ST elevation. You had the clinicians checking inclusion and exclusion criteria. If it was appropriate, they were obtaining informed consent and thereafter randomizing them to either immediate angiography, where they were taken directly to cath lab, or they were kept on intensive care with delayed angiography if the indication became apparent. The primary sort of outcome that they were looking at was 30-day all-cause mortality, and this was followed up with 6 and 12 monthly phone calls. The study was conducted across 31 sites across Germany, and it was obviously sort of quite a large study, impressive study at that. So in terms of patients that were considered for inclusion, there were 558 patients. 4 of them were excluded for lack of informed consent being followed. So 554 patients were randomized, pretty even distribution across the 2 groups in terms of numbers. In terms of how many were analyzed, so there were a couple of patients that were excluded for the reasons that are listed there. But in terms of how many patients were analyzed across the 2 groups, you can see it was an absolutely equal number across the 2 groups. Just it's IT. Sorry, apologies for that interruption. So in terms of, there are a couple of patients that were excluded from analysis on both sides, and you can see the reasons that are there. So in terms of outcomes of these patients, the primary outcome, as we mentioned, was 30-day all-cause mortality, and the secondary outcomes were looking at the basically complications of cardiac events, how long patients stay in hospital, what is the neurological outcome, and then looking at things like bleeding, stroke, and kidney damage that could be related to the angiography itself. So if we have a look at the graph that was produced by the study, you can see that as time went on and days after randomization went through, the probability of survival dropped for both of these groups. Yes, there is a slight separation between the groups. If you have a look at the analyses that were done, the p-value is not of statistical significance, and the hazard ratio that was produced has produced a value of 1.28. Now, what I want to do is hand over to my colleague Alex, who's going to explain hazard ratios, and this will better contextualize the outcome of these studies.
Hi there, thanks for that. Just had to nip outside briefly. Okay, so as Brent said, we're just going to do a brief chat about what actually hazard ratios are, just to help you to kind of contextualize what the numbers mean. So the key thing really here is that hazard ratios differ from odds ratios or relative risks, which is what you might be a bit more used to seeing in studies. And the kind of key difference really is that a hazard ratio is looking at the likelihood of an event happening at an individual point in time. So in this, if you look at a Kaplan-Meier graph, what that's showing is, or it's the graphical representation showing the hazard, i.e. the chart. What are you doing? The hazard of that event happening at that particular point after randomization. Okay, and in this case, that hazard is death, or conversely, the sort of survival. And you can either have positive or negative hazards. So a sort of positive hazard might be the chance of achieving hospital discharge, or a condition getting better, or cancer going into remission. A negative one might be time to death or time to relapse, and it's usually used in a time-based sort of fashion. And the hazard ratio is purely looking at comparing the likelihood of that hazard occurring in the intervention group versus the control group. And as we said, it's shown graphically on a Kaplan-Meier curve. The way that those are actually sort of derived is if you imagine they kind of take the data for all the patients who may or may not have complete data over the course of the study, and they basically look at, for a given period of time of enrollment in that study, how likely the event is to happen within that time period. And that's where you get that kind of what looks like a sort of survival type curve. It's not the sort of it's not the way you necessarily think it works, in terms of it just showing how many patients were alive at X days post randomization. It's sort of done on a sort of like more statistical basis. In broad terms, to interpret a hazard ratio, if the hazard ratio is 0.5, then half as many patients in the treatment group have had that event compared to the control group. If it's 1, then the event rate is the same. And if it's 2, then it's more likely to happen in the treatment group compared to the control group. So if we look at the results from the next slide, no, forward. That's fine. So if we look at our hazard ratio of 1.28 here, that's essentially saying that actually our hazard here is the risk of death. At any given time, there's a higher likelihood of death in the immediate angiography group versus the delayed angiography group. And we can see that on the graph in that they sort of more rapid drop off in the immediate angiography group. Notably, they didn't actually reach statistical significance. So you're not necessarily saying that there's clear evidence that immediate angio is harmful. You failed to show a benefit from the intervention. Can we go forward again, please, Chris? Next slide. And just to reiterate, there's a difference between hazard ratios on the right and risk ratios on the left. So risk ratio is it's assessed over the entire duration of the study versus a hazard ratio, which is a point in, it's assessed at an individual point in time. And the risk is the likelihood of it happening over the entire duration of the study. There are some limitations to each. So for a hazard ratio, you need to assume that the event rate remains relatively remains relatively constant between the two groups over the duration of the study. To establish a risk ratio, effectively, you need to assume that the study design has a representative population. It doesn't work with case control studies. That's where you'd end up using an odds ratio. And as you said, risk ratios are static, hazard ratios are dynamic over the course of the study. Okay, next slide. That's just our Kaplan-Meier curve reappearing again. Okay. So I think it's Chris's turn now. Oh, and this is, yeah, we talked about that.
So this is kind of the overall, sorry, excuse me, my voice is a bit hoarse. So this is the kind of overall results of the paper. So what I found was that comparing immediate angiography versus delayed or selective angiography, as Alex explained, that this strategy or intervention did not reduce the 30-day risk of death from any cause compared to kind of the delayed or selective strategy. It's important to note with these results that the secondary outcomes aren't adjusted for multiplicity, and therefore they may not be reproducible in other studies. But overall, 30-day death from any cause of severe neurological deficit was 64.3% versus 55.6% in the delayed group. This gives a relative risk of about 1.16. Now, interestingly, in the 30-day mortality of myocardial infarction, it was 0% in the immediate group and 0.8% in the delayed selective group, which kind of fits potentially with the delayed strategy, picking that up. The kind of overall sort of secondary outcome in this was the severe neurological deficit, and that was classed as a cerebral performance score between 3 and 5. So 3 being kind of severe neurological deficit to 5 being brain stem dead. And what they found was that in the immediate group, it was a lot higher. So again, 64.3%. And then what they also did was just kind of interpret the remainder of the data to look at the kind of other features that maybe are kind of in keeping with the risks of the procedure itself. So moderate and severe bleeding in the context of angiography, stroke in the context of angiography, and then the kind of old favourite of contrast related renal failure requiring renal replacement therapy. And they found that was slightly higher in the immediate group. So the kind of overall results of the study, as we say, was that it resuscitated patients with possible cardiac cause of hospital cardiac arrest with no kind of ST changes on left bundle, giving them an angiography immediately did not reduce their 30-day risk of death. of any cause, compared to a selective angiography strategy. So that delayed or selective strategy, as we talked about, was bringing them to ITU, and then making a decision and optimizing their physiology. It's important to note that within the delayed strategy, there was a clinician discretion that basically if the cardiac markers raised, so specifically if the troponin I was 70 times the upper limit of normal, or the creatine kinase went to 10 times the upper limit of normal, or there was new electrical instability, and the clinician could basically refer the patient for an angiography within 24 hours. And that kind of comes into kind of the strengths and the weaknesses of the study, and that demonstrates some crossover. So in terms of the overall strengths of the study, the baseline characteristics we felt were very well balanced across the intervention and control groups. So specifically, between the two groups, the median age in both populations was around 70 years. The 30% of the patients were female, and 37% of the patients already had known coronary artery disease. Within both groups, the time from cardiac arrest to ROSC was around 15 minutes, and 55% of the patients had shock of the rhythm. In terms of the other characteristics, the median GCS score was 3 in both groups before intervention. I think overall the study had very clear and good secondary outcomes, and they were very defined. It was multi-center, and that was specifically in Germany, and I think the other area was Norway, if I'm not mistaken. Sorry, Denmark. So 31 trial sites in Germany and Denmark. It was also an intention to treat, so all patients were included in the statistical analysis, which you can see from the breakdown. And there's a patient-focused primary outcome as well. The randomization protocol was very well defined, and they basically used a computer-based system based in these hospitals that they were doing the study in, that allowed it to allocate patients safely and quickly. So in terms of looking at the overall study, the kind of issues that we found was that, again, there was clinician discretion used to establish hemodynamic instability. So again, I guess it depends what you class as hemodynamic instability, and that obviously opens itself up to bias, which may in turn influence the overall outcomes of the results. That also kind of falls into the kind of some of the issues that we found that 22 of the patients violated the study protocol. So specifically in the delayed group, there were 46 patients in that group that had angios within 24 hours, of which a significant number of that didn't meet the criteria for the raise in cardiac markers, so specifically the TROP-I levels and the creatine kinase. So that was the other issue that we found. The other problem we felt with from the analysis side was that the study became unblinded at the analysis level, so essentially became an open label study, and that again opens itself up to bias. And then one final point really was that the follow-up of 30 days, it sort of caused an issue really, because it's, yes, you've got your secondary outcome of kind of myocardial infarction or renal replacement therapy within 30 days. Those are all relatively acute things, but actually cardiac remodeling is a chronic process following this, and obviously the study itself doesn't take into account the kind of effects of myocardial fibrosis and cardiac remodeling, which in turn may have a more significant impact on patients' mortality. So that, yeah, kind of more or less brings us to an end of the study. and the discussion of it. So special thanks to Dr. Van Manen again for kind of putting these slides together for us. But just want to really open it up and just see if kind of there's any particular questions on it. I've got paper in front of me, so if there is anything you want to discuss or any other details of it, I'm happy to provide that.
Thanks very much, guys. Are there any questions? I'm just thinking.
Certainly none from the participants who are here in the room with me at the moment.
I guess the thing is, would it change practice in what we're doing at Northampton?
I mean,
yeah, well, I think the current protocols in Northampton are that patients that are post-ROSC without evidence of STEMI are not transferred for immediate angiography anyway. So I don't think this is going to change practice. I think most of those patients, if appropriate, are transferred to critical care and then discussed with cardiology for ongoing management, which is kind of what this paper is suggesting is sort of a reasonable study or reasonable treatment protocol.
Yeah. Is it different in other centres, do you guys know?
Not that I'm aware of.
Excuse me. So the difference between ST elevation and non-ST elevation is, from what I understand, is the non-ST elevation, you don't have an infraction. There's just a thrombus, which is partially, there's ischemia. So, and in ST elevation, you have infraction.
Yeah, so basically what the study was looking at is if you have a clear-cut MI versus not clear-cut MI, does it angiography make a difference?
I mean, if you do intervention in a non-ST elevation MI, you're dislodging the thrombus, and it can, you're removing the cap which is present, and you're furthering the development of it. Thrombus.
Yeah, and I think also what we were talking about was actually that potentially, you know, if you commit everyone to angiography, you kind of, it always gives you a little bit of confirmation bias in some respects. So, you know, a patient comes in, yes, they've had an ANSTEMI, yes, they have an angio, you might be more inclined to kind of stick to that diagnosis because that's been kind of written down. Think of other causes or non-cardiac causes of cardiac arrest, which you potentially miss. You said there's the potential risks of it. But then I suppose yes, you could have one, but it's only immediate angiography is only going to be useful if you've actually got a lesion there that can be stented. And I think what we study why was the modality of choice in this and not kind of coronary artery bypass grafting, just because it's done obviously in an emergency setting.
But yeah, Alex, going back to what you were saying, I don't know if there are sort of different protocols in different centres, certainly not that I've been kind of, well, made aware of or heard of in terms of taking all patients to cath lab. I don't think that would be, well, certainly none that I'm aware of.
Mm. Yeah, I wonder, is there NICE guidance on this? As in, is there a national kind of protocol? I'm not so familiar with cardiology, so I don't know if there's a national guidance on it, or if it does indeed vary from place to place depending on the cardiologists and what they like to do.
I mean, there's the ERC guidelines, which were in 2021, and they basically just said you need to consider it if you've got a high suspicion of coronary artery occlusion.
Yeah.
So,
yes, I don't think there is NICE guidelines for this. I think the sort of reason for the study was based on those ERC guidelines that were released about, you know, having a high index of suspicion.
and it was maybe just looking at whether it's feasible for kind of all cardiac arrests, or what is the benefit of it.
Okay. That's great. Thank you very much, guys. If there are no more questions, then I will stop recording.
Cool. Yeah, no, all good. Thank you.
Thank you.